Hello, Dr. David McFadden here again from the Dental Implant Center in Dallas, Texas. Today's topic I think you're going to find is a very interesting one. I always like to start by showing my office. I don't know why I do that, but I want you to know where I work. So today's topic is implant bridges versus all-on-4 or implant dentures. Those two words are kind of synonyms. A lot of patients call all-on-4 an implant denture, which is perfectly fine because that's what it actually is. So I'll start by just throwing the question out there. Which would you rather have in your mouth? Would you rather have something that looks, feels, and functions just like teeth? Or would you rather have something big and massive that feels like a denture for the most part in your mouth? This pink portion here today is going to be part of what we focus on as we go forward and throughout this presentation. So it's kind of a rhetorical question, I think. I mean, I don't know anybody who would pick that over that if you had the choice. So we get this question online on the YouTube channel. Patients who call the office ask this question all the time. Can you refer me to somebody near my house that does implant bridges? And in the first few years we were on YouTube, I actually made a concerted, sincere effort to find people who do implant bridges in those areas. But all-on-4 dominates this market, absolutely dominates the market. And I finally gave up. There was just nobody. I couldn't find anybody. Then I got feedback from patients that finally did decide to come to Dallas, and they said, you know, we could not find anybody that would do an implant bridge like you do it. We've even gone and interviewed doctors, and some of them will falsely call an all-on-4 an implant bridge, but it's not. We're going to talk about those differences today, and why all-on-4 dominates the market, and why implant bridges are less than 1% of implant reconstructions nationwide and worldwide. So there's one primary reason that differentiates the implant denture and the implant bridge. And the reason that you don't have the opportunity to get treated close to your house, why you might have to fly 5,000 miles to get an implant bridge, is they are incredibly difficult to do well. Incredibly difficult to do well. Number one reason. Get into that a little more later. So I planned on doing this video for months, maybe even a year. But the real reason that I decided today was the day is I've got a local colleague who put out a video not too long ago basically condemning implant bridges. And he said, yeah, I tried one on my father and it didn't turn out good. I really wish I would have done an all-on-4. So I showed this cartoon. This is a technique or a protocol that's taken me 30 years to perfect. And it's still not perfected. It's really, really good. But every patient, every week, every month, I see ways I can improve the protocol that I developed. So I put this cartoon up there to make the comparison. So let's say that you went to putt-putt golf for 20 years. Then you started going to top golf for a few years. And you thought, hey, you know, now's my day. I'm finally ready to go play golf. You go to the golf course, and if you're actually keeping score accurately, your first time on a golf course, you're going to shoot 130. You're going to take 130 strokes around 18 holes of golf. So even though you had some experience in golf, the real game of golf is so difficult that you're going to condemn the game after one round of golf because you couldn't do it well. I mean, it's ridiculous. Like golf, the dental implant bridge that we do here, it's very, very difficult. And it takes years to go through the learning curve that it requires to hone your skills. Little nuances of treatment become big game changers in the overall outcome of these implant bridges. And really, a prosthodontic office is the only place you're really going to get that, because the logistics of trying to work between two different offices, for example, an oral surgeon or a periodontist would have to schedule a half a day with a prosthodontist to come to their office to make the temporary that shapes the tissues, like I'll show you later. It's a logistic nightmare for any other office than a prosthodontic office that does the surgery and the prostheses, because we often have to make multiple temporaries to get the outcomes that you'll see later in the presentation. But what I think is also super, super important to remember about my colleague saying that he tried an implant bridge on his father. So there's a lot to talk about in that statement. That particular doctor wanted something better for his own family members. So he wanted to do an implant bridge for his father, but yet his specialty is All-On-4. So think about that. Just think about what the underlying reason was. He wanted something better for his family than he does for his patients on a daily basis. I'll leave it at that, but thank you, doctor, for encouraging me to make this video. So anyway, we'll get back to the topic at hand. There are two secondary reasons that implant bridges aren't as popular as implant dentures. First one is cost. Yes, they cost more, but as I'll show you later, I believe it's a reasonable higher cost to justify a much better restoration. And the treatment time can be extended for patients who come in with really bad teeth, not so good bone, etc., etc. We'll talk about that as well. So 3 basic reasons, one primary one being they're super difficult to complete well, the cost and the treatment time. So I've showed this lecture, I've showed this part of the lecture to other dentists when I've given this at a professional level. But I want to talk about the All-On-4, how it all got started. I call it the pandemic because when I first came up with this idea, it was during COVID. But the original implant denture started in 1965 in Sweden by a doctor named Brannemark. And it took 20 to 25 years to really spread around the world to become a popular implant restoration or a popular implant protocol. And in their early versions of this treatment, they put out a statement about what they were doing. And I'll just highlight this in the next slide. They stated that using a very cautious method to show the greatest possible degree of respect to the living bone tissue. That's a really important statement. In the next few minutes of this presentation, we're going to talk a lot about bone and the bone reduction that the All-On-4 protocol demands. So then we'll talk about All-On-4. It really started in about 1993 to 1998, but the clinic in Lisbon, Portugal, opened for business doing All-On-4 in about 1998. And over the next 20 years, it spread to be this worldwide pandemic treatment protocol that I don't really approve of. So, like I said, Dr. Mallow in Lisbon, Portugal, developed this technique, implemented in his clinic in 1998, and it was developed just like Dr. Brannemark's protocol. It was developed and intended for people that were already missing their teeth. Now, this is of paramount importance in you understanding the difference between implant bridges and implant dentures or All-On-4. Intended for people already missing their teeth. So the key differences between 1965 and today, the All-On-4 offices use angled implants and angle correction abutments. Think about that. Another really interesting picture. Back in 1965, they did 4 parallel implants. Fast forward 58 years, and the only innovation, the only difference is that now we're putting the implants at angles that have to be corrected with an angulation abutment. Shame on this industry. Shame on the dental implant industry. Almost 60 years, and the only thing we've come up with is changing the angle of the implants? It's shameful. Any other industry that's only made this much progress in 60 years, can you imagine? Hip replacement surgery, heart surgery, ophthalmology procedures, lens replacement, all the other industries have gone through massive technological improvements. And this is all dental implant can come up with? Shameful. To me, it's a giant step backwards. It's not even an innovation. It's not even an improvement. It's a giant step backwards. Both of those treatments, Dr. Brandemark and Dr. Mallow, again, I want to stress this point. Those procedures were designed and developed and intended for people missing all their teeth and a lot of their bone. So how did it become this worldwide pandemic? How did it become the #1 dental implant procedure in the world? So let's get into that. So like I've said in my other videos, people that come to us for full mouth implant reconstruction only represent 10% of our new patients. 10%. So 9 people come in with teeth for every 1 person that comes in with no teeth. So again, I'm going to stop here and ask you to think about that ratio. 2 treatment modalities that were intended for people without teeth are now being used for 100% of the patients who present for treatment. So why is the dental implant industry treating patients with teeth the same as those without teeth? Pretty important question. I'm not even going to comment except just show you the picture. So I've said this before and I'm going to say it again. If you have some or all of your natural teeth that are failing or have failed, All-On-4 is not the best treatment for you. And in case you missed it the first time, I'm going to put it in red. If you have your teeth, that usually means you have your bone and your gum tissues, at least some semblance thereof. If you have some or all of your teeth, there is a much, much better treatment for you than All-On-4, and it's called Implant Bridges. And I would go one step further. Even if you are missing all of your teeth and have been missing all of your teeth for some years, All-On-4 still may not be your best treatment. I consider the All-On-4 protocol, the same as I do zygomatic implants, pterygoid implants, I consider it the very last option for people missing 90% of their bone. It's the option at the very end of the dental implant road, the very last stop for those few percent of you that are missing 90% of your bone. So let's start the actual, I'll stop ranting for a while and I'll start showing you and educating you on some of the things I think you need to know going into this huge, perhaps the biggest decision you've made in your life about fixing your teeth. So I have these models of, these are bone resorption models that I keep at my desk and I show patients. Many times people don't know why their dentures get loose or why their mouth appears to be sunken in after many years of denture wearing. But it's really because of this digression. People with teeth they start with 100% of their bones. So let's say 18-year-olds, their mouth may look like this. And if you're lucky genetically and you've got good dental genes and you take care of your teeth, really there's not many changes that happen throughout your life. But if you're less fortunate genetically or you haven't taken care of your teeth, you may start losing bone around your teeth and end up in dentures. So if you look at the thickness of bone as the digression happens, this, after the teeth come out, this might be in the first 5 years, this might be 10 years, this might be 15 to 20 years. But that's, and I'll show it to you in different views. So this is the upper jaw, looking at it from a different perspective. Robust, thick bone, still decent bone, and we can still do beautiful implant treatments here. Gets a little bit more difficult here and much more difficult here. But I will tell you that only a few % of you actually ever end up here. And still from a different perspective, a side view, full bone, 90%, 50%, 20%, whatever, it's an arbitrary guess that I'm making, but you can see the digression or the progression of bone loss as time passes without teeth. The lower jaw is a little more easy to show because of the way the model is set up. Here you are at 18, and let's just go through these. This is from the top view, and you can see the thickness reduces with each decade of bone loss. But this is probably the most profound picture that I took of this model. Look at how much bone there is here. It's reduced by maybe 30% here, 50% here, 80% here. So this patient, this is the person that All-On-4 was intended for. This is the person that the Brannemark treatment was intended for. And this only represents a very small % of our population. So let's talk about that All-On-4 protocol of bone removal called alveoplasty. And in one of my other videos, you'll see that I actually call it alveolectomy. Alveoplasty is the smoothing of bone. Alveolectomy is the complete removal of chunks of bone. And that's really what this procedure does. In my other videos, and we'll show you links to those other videos below near the comments, but these are the 7 things that I don't like about the All-On-4 protocol. But these first 2 are the ones that are really driving the negative impact of All-On-4. These are the 2 that drive all of the other factors, really. So we'll talk about bone reduction, and I already said alveoplasty versus alveolectomy. If you haven't watched my video on that, please do. It's powerful. Educate yourself on what you're signing up for. All-On-4 requires extreme bone reduction. I'm not going to go a lot into why, other than to say it's all in, we have other videos about that. But the main thing I want you to understand is that the protocol calls for 11 to 15 millimeters of bone removal, and that depends on how big of a person you are and how much bone you currently have. But just to give you some reference, 12.7 millimeters, which is in the middle of this range, is a ½ an inch. Imagine a ½ an inch of bone removal in your mouth unnecessarily. And this is what it looks like. This came from an All-On-4 lecture. Reciprocating saw, cutting the bone out. If that doesn't make sense to you, I made this video as part of another YouTube segment that we show. So they take a person that may have 100% of their bone and they take them down to that last person, the bottom example on that model that I showed you. So there's even doctors out there who on social media brag about how fast they can do it. I'll let you draw your own conclusions. So again, I just want to make sure that I'm showing you every angle, every image, every graphic that it may take for you to understand what's about to happen to you if you get All-On-4. You have bone like this, and within a few hours, this is you. So you come in with some or all of your teeth, 3 hours later, this is the new you. Does that seem like something that is right? Does that seem like something that you would sign up for knowingly? Well, not sure how I can say this legally, but alveoplasty and alveolectomy are either ignored or downplayed at your new patient visit. Most of the time it's not mentioned. I've treated a lot of All-On-4 patients before and after their treatment. And they're completely surprised by this, that they have not been informed about the bone removal necessary to do All-On-4. So anyway, I think you understand what I'm getting at here. So why? Why would you take a patient with this much bone and turn them into a patient with this much bone? Or like on the last slide, why would you take a patient from here to there? It's a philosophical question, I guess, but there is an answer. When you take that bone down to a wide platform, every patient's the same. It's fast, it's easy, and it's lucrative. So we'll dive into that a little further. By removing all the bone, every treatment becomes the same. You'll hear me mention later in the presentation production line implant dentistry. So once that bone is gone and you're down to this platform, you are the same patient for the doctor. So when you're there on the day of surgery and you're draped up and ready for surgery, you are not unique anymore. You are the only thing separating you and any other patient treated last year, last month, earlier today, later today, is your appointment time. Are you the 7 o'clock patient? Are you the 10 o'clock patient? Or are you the 1 o'clock patient? That's it. That's the only way you're different than every other All-On-4 patient that they treat. But yet, in our lectures, we always hear this buzz phrase, no two patients are alike. That's true in my practice, and I'll show you why in a minute. But in these practices, that's the only thing separating patients, is what time your appointment was. Who do you think benefits from that? Do you think the patients benefit from that? Or do you think maybe we're back to this age-old problem? And it's counter to what we all signed up for when we graduated dental school. Same as the physicians. Our creed says, do no harm. In dentistry, we preserve healthy tissues whenever we can, starting from our very first filling as a second-year dental student. Take away the least amount of tooth structure to get the job done. Preserving healthy tissues. And the other part is kind of an unspoken creed, is that patients are supposed to have options. And if your only, what's the saying? If your only tool is a hammer, everything looks like a nail. If your only treatment rendered is All-On-4 and you end up in that office, what do you think you're going to get? So we're back to the intention of the presentation, and that is to talk about why implant bridges are so rare and almost literally impossible to find, the difficulty. So I want to contrast, well, I'll make the statement first. They are infinitely more difficult to do well than All-On-4. And I hope that in the next few minutes I'll show you why. So let's contrast, right out of the gate, let's contrast All-On-4 treatment with implant bridge treatment. In this production line treatment, the diagnostics are easy. Remember the slide where we're down to that single platform? There's no real need for any thorough diagnosis because we're taking all your teeth and most of your bone and turning you into a dental implant zombie. I just made that up, by the way. Every patient ends up being the same. So that means your treatment plans are the same and your treatments are the same. That defines production line, right? So the doctor may or may not even look at your CT scan. He may or may not even look in your mouth. The only ones they struggle with are when they overpromise All-On-4 and find out the patient really doesn't have even enough bone for All-On-4. But that's how simple diagnosis is in the All-On-4 office. More time is spent trying to get you financed for the treatment than figuring out what you actually qualify for dentally. Okay, let's contrast that with implant bridges. So because we're not sure every tooth has to come out, we have to make a tooth-by-tooth assessment. Many times patients think they need all their teeth out, and they don't. More often, though, people that have failing dentitions, mutilated dentitions, or terminal dentitions, they know it, and most people that come in do need all their teeth out, but not all. So we are going to do a thorough exam. We're going to do full radiographs. We're going to do a tooth-by-tooth evaluation. We're going to decide whether the patient maybe needs stage surgeries. That means they need staged temporary bridges. Do they need bone grafting? What final prosthesis material are they qualified for? Because there's a big difference between people who clench and grind and those who don't. And shockingly, probably 60% of our population grinds their teeth. So I don't like acrylic against acrylic, and I don't like zirconium against zirconium. There's a sweet spot in the use of the materials that will give you the longest lasting, the lifespan or the service of these restorations. And how are we going to protect this if you are a grinder or a clencher? How are we going to protect it? How many times a year do you have to get your teeth cleaned? So we're going to look at a full mouth series of x-rays. Make sure we're not making any mistakes on viable teeth or bone volume. We're going to take panoramic x-rays. We're going to take CT scans and we're going to review them. Because again, I'm making decisions on implant position from an engineering standpoint, a biological standpoint, and in that biological standpoint, do you have enough bone for an implant where I want to put it? So we're looking literally every tooth, every slice, and trying to come up with a plan on how we're going to treat every patient individually. It's custom treatment planning and custom treatment where your treatment is based on your diagnosis, your bone volume. There's so many things to consider. We're going to get into that in just a minute too. But when we look at, this is a patient with very bad bone, okay? And again, sometimes we can't do implants on everybody. It's super rare, but patients with bone like this, we struggle in coming up with a treatment plan to fix them. Then after all that, after we talk to the patient, we make our diagnosis, there's other questions that we have to answer because, again, we're not on a production line. Everything is custom. So what do you want? What does, many of you come in having done many, many hours, weeks, months, and maybe even years of research. You have an idea of what it is you want. I want to hear that. Can any of your teeth be saved? Are you motivated to save them? Do I think it's a good idea? A lot of questions to answer. What can you afford? We're not going to sit with you for 4 hours to try to get you financed through multiple different high-interest credit cards or multiple different lending institutions and saddle you with that kind of debt. So maybe we can fix your mouth in a different, less expensive way. What can you keep clean? How old are you? Do you have rheumatoid arthritis? Are you motivated to keep your teeth clean if we give you something that's a little more difficult? How do we maintain natural tissues? And that's a big thrust of what I'm going to talk to you about today. Will the final prosthesis have pink on it? I'm going to answer those questions later too. Which sites are potential implant sites and how many implants are we going to use? And if that wasn't enough, we've got another page of questions. Cantilevers. Can we put a tooth or 2 teeth behind your last implant? How long of the bridge part can we have without implants underneath it? How many surgeries are you going to have? Many of our patients travel from out of town. What are the logistics of that and how can we maximize each visit while you're here? Do we have enough dental implant inventory? Because again, no patient's the same in our treatment style. We have to keep hundreds of implants in inventory here No matter how much diagnosis we do and how many measurements we make, we have to keep hundreds of implants here so that we have the right implant for the tooth position that we're placing the implant into. So the companies make implants from 6 millimeters long all the way up to 22 millimeters long. Diameters range from 3 millimeters up to 6 millimeters. So you can imagine how exponential the inventory has to be to meet all our needs. Do we have enough time in the schedule to do everything the patient would like us to do or everything we're trying to do? Is the patient psychologically ready for treatment? And I'm not a psychiatrist or a psychologist, but I can tell you after 35 years that some patients have been without teeth for so long that they cannot accept teeth. Even if they're small, and even if they fit perfectly, and even if they look fantastic, I've had a handful of patients during my career that were not psychologically ready for teeth. It's a hard assessment to make, and usually, unfortunately, we only find that out afterwards, but we all, being optimistic and hopeful, we would like to take a person that hasn't had teeth for 10 years, give them teeth successfully, and have everybody be overwhelmingly satisfied. And usually that's the case. But this is part of what we're interviewing the patient about. So, and like I said earlier, during the diagnostic phase and the treatment planning phase, we're making tooth by tooth pre-surgical decisions that have to translate into the surgical decision. But how much sedation is appropriate for that patient? How much bone volume do they have? What is their general bone density? Are any of the teeth infected? Are there any teeth that are good enough to serve us short term to hold the first temporary? How much tooth is going to be shown when the patient smiles? There are literally dozens, if not hundreds of decisions that need to be made when you're doing custom implant reconstructions, as opposed to implant dentures where everybody becomes the same patient. That's the difficulty part starts even before the surgery. Even before the treatment, the difficulty starts. So, more surgical, pre-surgical decisions. Do we have enough room for the teeth? I mean, I know that sounds weird, but some people have so much bone that the bone is where the teeth should be. That's part of our diagnosis. How hard will the teeth be to get out? We've got patients, and I jokingly refer to them as Neanderthals because their teeth are like in concrete or granite. I have worked over an hour taking one tooth out. Not because I'm slow, but because if you force a big tooth out of the bone too aggressively, you break the bone. Well, I'm not taking a 0.5 millimeter of bone away from my patients, so every little bit of bone is precious to me because I want to use it to give them back, well, to maintain, right? So if I break the bone from taking out a tooth too aggressively, that hurts the overall final product. The teeth don't look as good. So that's a big question I always ask. And also, how hard are the implants going to be to get in? Some of our patients can only open that much, and we're trying to work in the very back of their mouth where they may have bone in the second molar region. So how hard are the implants going to be to get in? How long will it take to make the temporary bridge, and how difficult will that be? Can the patient tolerate the time, right? So we've got some medically compromised patients. We've got some older patients. We don't want them here for 10 or 12 hours. We may have to break up the treatment into segments or do the upper arch first or the lower arch first. And do we have enough? As if the implant inventory wasn't enough, we need hundreds of pieces of prosthetic parts to make all this come together. So there's a lot of decisions to be made when you're actually getting custom dental implant treatment. So, as if that wasn't enough, right? Now, after all that planning, all those questions, now I actually have to go do it. So, this part is extremely difficult too. And I'll tell you that it's as fulfilling as it is, it's also exhausting. When you're trying to treat a sedated patient gently, but with extreme quality, it's exhausting. So we do one of these a day. And I mentioned earlier that you're the 7 o'clock, the 10 o'clock, or the 1 o'clock patient. Many of the All-On-4 centers may do 2 patients, 4 arches, 3 patients, 4 arches. They may do 3 of these a day. And I can tell you that surgical exhaustion is a real thing. I try not to have to do anything longer than 3 to 4 hours. But sometimes we run over. Sometimes treatment is more difficult than we anticipate. But I'm going to show you the first case. You may have seen it before in my other videos. But in the last 2 years, I've come up with a way to do these treatments in a staged approach. And the reason is it yields a better result. It's my solution for patients who may not have enough bone density to get their first temporary on implants, but we don't want to give them a denture either. So let me take you through this, and I think it'll be a little more clear. So patients come in with a varying range of tooth problems. This lady has great bone and gum tissue, but she's got cavities everywhere. Literally all of her teeth are unsavable, non-salvable because of caries or dental decay. But her gums and her bone are good. So obviously if you take away a ½ an inch of bone, the patients are never going to have anything that looks or feels like teeth again. So our goal is to try to disturb that bone and the soft tissues as little as possible. So what I've come up with, and this is like the latest development in my protocol, as I'm trying to always make it better. Here's her x-ray. You can see the size of some of the cavities and some of the broken teeth because of the cavities. But every patient has a different level of bone density, and it's usually a genetic thing. If you have soft bone, we usually can't put temporaries on your implants on the day of the first surgery. And that was always a problem because that interim time of wearing a temporary denture caused the tissues to change in a negative way. So I start all these surgeries off as a staged treatment, meaning we're going to have to come back and do a second surgery 2.5 months later. And here's how it goes down. My colleagues who do the implant dentures or the All-On-4, first thing they're going to do is take out all the teeth. Then they're going to open your gum tissues up to expose the bone. Then they're going to remove that ½ an inch of bone everywhere. So even as recently as 4 years ago, I would take all the teeth out, put the implants in, and hope for the best from bone density, implant stability standpoint. Well, I often hit the problem that have all the teeth out, I have all the implants in, but they're not strong enough to hold a temporary, so then the patient had to go home with dentures for 2.5 months. It was horrible for them, it was disappointing for me, and worse yet, it was hard on the tissues in the bone to wear a denture. So what I do now is I talk to the patients. I'm going to take strategic teeth out. Obviously, all the really bad teeth are coming out first. But any tooth that could serve as a short-term abutment for 2.5 months, we're going to leave in. So I'll take all the bad teeth out, I'll separate the bridges, and I'll put my first pass of implants in. So I got 5 upper implants in, 4 lower implants in, but none of the implants were strong enough to hold the temporary. But I haven't burned the bridge. I left 6 teeth in the upper, 4 teeth in the lower, so now the patient can go home with a beautiful fixed temporary, comfortable, aesthetic, and then while the implants are healing at that microscopic bone level, they're not suffering in any way. In fact, many of them leave here much better off than they came in. So this is the temporary that we give the patient on the day of surgery. And just in case, well, I'm sure you weren't counting teeth, but just to remind you, we have these 6 teeth that are left, and that's what's supporting this bridge for 2.5 months. Patient goes home and heals. The implants are healthy. They come back at 2.5 months. And you can see we get a little bit of tissue shrinkage, which is normal after surgery. So we've got implants that are now healed and teeth that helped us for 2.5 months. So that this appointment, then we take the rest of the teeth out, we put more implants in, and they leave here with a temporary on all implants. So now the implants are in this position and it's holding the temporary, but we still need the patient to heal for 2.5 months so that when we make our final impression, none of that same shrinkage happens between the impression and the final product. So very methodical, staged approach that yields the best results. So here she is after 2.5 months with her temporaries, and here she is with her final restorations. So the reason we didn't lose these pink papilla and bone volume was because she never wore a temporary denture, and those temporaries actually put pressure on the tissues to stimulate them to stay where they are. The permanents will do the same. But this is my latest big game changer for patients getting full mouth implant bridges, is that if you've got some viable teeth, they kind of have to be spread out. They can't all be in one spot. But if you've got some viable teeth, we can do your treatment stage so that you never lose the bone and the gum tissue. So here's where we started. Here's where we finished. 0 bone removal. 0. So the second problem with All-On-4, that giant step backwards that I talked to you about earlier, is the use of angled implants and angled abutments. So in order to go even faster, either be done with your surgery sooner or see more patients every day, the implant surgeons were now putting implants in fast because we've got angle correction abutments. They come in 17 degrees, 30 degrees, and I believe now they're even up to 45 degrees of angulation correction. So imagine that. Imagine that some doctor, for some reason, and they're always going to say bone availability, the implant had to go in at that angle because of bone availability or bone anatomy. Their patients are the same as my patients, and yet somehow I'm not limited by that. So a 30 to 45 degree angulation correction. I mean, in any other profession, in any sport, if you were off by 45 degrees in anything you were trying, you wouldn't be in that profession. You wouldn't be in that sport. So that's the second part that's really caused problems. So when I mentioned to you the difficulty, one of the reasons that implant bridges are so rare and they cost more is that the precision necessary to place these implants exactly where they need to be to support the patient's implant bridge, to be cleansable, and to not show when they smile. These holes do get filled in with white filling material called composite resin, but you can imagine if that hole is on the front of the tooth and we have to put a white filling material in there, it's going to stain over time. You're going to have this beautiful tooth around this little dot of dark stained composite. So imagine any of us doctors who do implant bridges, this is time and energy and precision takes longer. But this is why it's so important, and this is why I'm so passionate about it. When you get it right, the tissue response is beautiful. So we've maintained this patient's tissues with proper implant placement, no angle correction abutments, and a direct clean connection from the bridge to the implant. This is what it results in. This is what every single one of you wants. This is what every single All-On-4 doctor would want if it was his or her own mouth. This is the gold standard for implant dentistry. Maintaining hard and soft tissues, which is bone and gum tissue, and maintaining the shape so that it's simply a recipient site. It's the frame that the teeth go into. So I hope by now you're recognizing why All-On-4 is so popular and why implant bridges are so rare. This is incredibly difficult. Let's go back and compare now. All-on-4 with a big 30-degree angled abutment. So now that your abutments are exposed, guess what your teeth are going to look like? So this is not even a terrible all-on-4 case. This is just what I'd call average. Are there better all-on-4 cases than this? Yes. Are there all-on-4 cases that you can clean on your own? No. Anytime any silver gets exposed in an all-on-4 case, it creates an immediate uncleansable cylinder around that implant. But everywhere else along the border of this is uncleansable also. It's concave instead of convex. You've heard me rant about that in many other videos, and if you haven't, we'll link some of those to this video as well. But anytime your abutment or your implant is above the gums, you can't make your prosthesis cover it. So anyway, let's just go back for a second. Which one would you want? An implant bridge where you've saved all your bone and gum tissues? Or an all-on-4 where they've cut it all away and had to put the implants at crazy angles? Again, I know it's a rhetorical question, but this is what you're faced with. Even if you find a really, really good all-on-4 doctor, you're still not going to be able to clean your prosthesis. So after we do this 1 or 2 surgeries, and sometimes you have to have 3 surgeries if you need bone grafting. We'll talk about that at the end. So we start a process to make the teeth that is also as precise as the surgery. We make perfect impressions of your mouth that also records the soft tissue contours. Then we have you back for records so that we're getting your bite right. Then we do try-ins. So the try-in part is also very, very important. If you love your temporary, and many times patients do, we simply mimic the temporary. If there's things about the temporary that you don't love or we don't love, then we'll make changes in the wax prototype. So this is made on the final cast, the master cast, using the temporary as a template. This particular patient, we wanted to shorten the teeth a little. They were a little too round in the temporary, so we made them a little more square. But all those tiny little decisions and nuances are accounted for in this stage. That wax up is tried in the patient's mouth. It's either approved or disapproved, or we have to make changes. And then we use that prototype or that wax try-in to make the zirconium bridge. All of our contours are convex, so the patient can clean. You can see how thin and delicate these are, mimicking the size of teeth, which is what everyone's goal should be and what your desire should be. I want implant teeth. Well, they should be just like my best natural teeth, or even better than my natural teeth. Then this is the final result. I've got a few times patients ask me how we made the pink zirconium look so natural. Well, it's not. That's her tissues. So this is as good as it can be done in implant dentistry. Literally as good as it can be done. Or you could have this, like we started out with. You could have this huge bumper of zirconium that you can't clean under, where your speech is negatively impacted because of the size of the prosthesis. And then the back teeth are cantilevered by 2 or 3 teeth off the last implant. Seems like an easy decision to make. So like I said earlier, implant bridges are infinitely more difficult than all-on-4, and that's why they're so rare. So I want to touch on the secondary reasons and explain those to you as well. The first one was cost as a differentiator between implant bridges and all-on-4. And the second one is the treatment time. So let's dive into those just a little bit here. So from a cost standpoint, it takes more time to do implant bridges. We expend a lot more energy doing implant bridges, and there are additional implants and additional implant parts and pieces. That's why they're more expensive. Our lab cost is much, much higher to do that beautiful, delicate little implant bridge than to be part of a production line where the lab technicians are making the zirconium, cookie cutter zirconium, in that same office over and over again every day. Everything's custom. But you wouldn't think that we could do it for 20 to 30% more. And depending on what All-On-4 office you've gone to, what discounts they're offering that day. If they're slow, they'll do it for less. If they're busy, they'll do it for more. So whatever you've heard, we may even be below this, we may even be a little bit above this. But in general, for all the differences, 20 to 30% I think is more than reasonable. And but we are going to be more expensive than a production line All-On-4 center. So from a treatment standpoint, a treatment time standpoint, we do get simple treatments that come in more often than not. And that's where patients have good bone volume, good soft tissues, and good bone density. And we can do it in 3 to 4 months, which is about the same time as All-On-4 or an implant denture. But again, not every patient's the same. So we have moderate treatment, moderate complexity. Those can take from 6 to 9 months, and typically those are the cases that we have to do 2 surgeries for. That's becoming more and more common as my protocol is getting developed, and we're so focused on the bone and the gum tissues and the architecture or the anatomy. This is more common now than it used to be. And then the really complex cases are where patients come in with very little bone, very few teeth, but still want something really nice. And we have to do bone grafting on those people. So 12 to 18 months would be the complex treatment. And the price difference between these is not a lot. I've tried to keep it as competitive as I can and just try to be as reasonable as I possibly can. Some of you watching this video may think, well, gosh, Dr. McFadden, this YouTube famous guy, he's probably richer than Jeff Bezos. And again, I was raised by blue-collar parents. I'm comfortable, but no, I'm not mega rich like you may think a lot of doctors and dentists are, but that's not the case. I could probably charge more for these treatments, but again, I'm trying to be competitive with a David and Goliath situation where Goliath is spending literally tens of millions of dollars per month on their product, and I'm creating YouTube videos in my basement. It's not really my basement, but you know what I mean. So the other thing that I get from other doctors and the occasional patient is that, well, how many of these have you done? Are you only showing your very best cases? And the answer is I've done a lot. I've been doing this treatment for 30 years. And so I just wanted to go through some patient treatments with you to prove that I have more than 1 or 2 cases. And I'm also going to link our gallery to you. I'm creating a page of just before and afters for these reconstructions so that you can get a different look at dozens of different patients and how their before and afters. Also, I've even had patients come in with a picture of somebody else's mouth and say, this is the way my mouth looks. Can I get this same result? I don't expect the gallery to be used like that, but I'm glad people are looking at it that closely. So this first patient I'll show you is a patient who came in with failing teeth. He had already had implants done at another doctor's office many, many years ago and never had them restored, which is another point I want to stop and comment on. The All-On-4 protocol, they will never use any existing implants that you have. Because again, the implants, when you're taking that much bone away, the implant's going to stick up like a tent pole. I would say in cases where our patients come in with reasonably well done implants, we use them probably 80 or 90% of the time, if they're reasonably good. I see no reason not to. Many of them have been in there for years or a decade or more, so why not use a healthy, good implant if you can? So I used all of his implants, but placed a whole bunch more in his upper jaw to give him this result. So before and after, And you'll notice no pink here. Another patient who comes in with terrible teeth and a terrible bite, but he's got good bone and good gum tissue. So his final result. Here's one that you've probably seen in other presentations. This was a lady I treated about 10 years ago, and I think it was that first big leap for me, where I went from some of the old protocol that I did well and successfully to some of the newer things that I try to improve on all the time. So this is one of our best treatments from 10 years ago. And again, you take somebody. Now, most doctors that do implants would look at a patient like this and say, well, she's been missing these teeth for decades, and say, well, then All-On-4 is her only option. Well, genetically, she had good bone, so we used it. We didn't take any bone away in either arch. Another case you may have seen, had some good teeth. She was a patient that we transitioned from teeth to teeth plus implants to just implants. And again, and we'll get to this at the very end of the presentation, but we can't always do teeth only when patients have missing bone. We'll talk about that. Here's another great case. The patient came in, really bad dentition, lots of things wrong with it, deep bite. We had to do some bone grafting on her, but we were able to get back architecture and anatomy that she didn't even have to start with. So I'm real proud of those kinds of cases. And yet another one, we're going to go into these next 5 cases are going to be people that had to have pink. It's still an implant bridge, still connects to your implants in that clean, cleansable way, still is convex, not concave. So a lot of people get really hung up on the pink, and I'm going to address that at the very end of the presentation. Before, after. Another guy missing many, many teeth, but had good bone, so why not use it? And yet another. You can't fully appreciate this because you don't see it every day, but this person was missing quite a bit of bone in both arches, and that's one of the reasons people have to have some pink in their final prosthesis. Bone loss is something we can't recover from a lot. Another patient before and after. These teeth had really bad decay. You might look at her mouth and think, well, her teeth aren't that bad, but on x-rays they were all bombed out with cavities. One of our biggest transformations ever. And I'm never going to tell you what color teeth that you should have. I am going to coach and mentor you, though, that people don't have snow white teeth naturally. And if you choose to get snow white teeth, I'm not going to stop you, but they're going to be too white for your complexion and your age. So we try to counsel people. Every once in a while, we get a patient, an 80-year-old patient, that wants teeth that are age appropriate. And just know that we can do that. They don't have to be this characterized, but that's what he wanted. And I'm really proud of my lab for being able to do that. And another. So notice how much bone loss here. We're going to talk about this patient in just a minute. So the big topic, and I'm going to address this even more intimately in another presentation that you can find the link to here, is patients get hung up because they've heard me talk about pink, the pink on All-On-4. Every All-On-4 case is going to have pink. With implant bridges, there's a certain percent of patients who have to have pink. And it's not up to me. I did find out one factor that is up to me, and I will address that. But if you come in missing bone and gum tissue, we do not have any way, unless you go without teeth for 7 months, to give you back all that bone and gum tissue and try to prevent you from having any pink on your prosthesis. So it's not in my control. And I've had a few patients tell me, demand, you said pink is bad. No, I didn't. I said people have pink on All-On-4s because they remove the bone. Our patients only get pink when I can't avoid it. But people get really hung up on the pink. And I don't want you to focus so much on that. And hopefully through this next few minutes, I'll explain that. So this is the one thing that is in my control. And I solved this problem 2 to 3 to 4 years ago. I don't remember exactly. I realized by taking so many pictures and looking at them so often that when I have patients who come in like that lady I told you with all the cavities in her teeth, what I used to do was take out all the teeth and put in all the implants. And if the implants weren't strong enough to hold the temporary, the patients were then, by necessity, had to wear a temporary denture for 2.5 months. So we put her in a temporary denture for 2.5 months, and look what happens to that beautiful tissue. So I got to thinking, how can we prevent this problem? One, patients hate temporary dentures. I hate it for the patients. And two, it has negative impact on the bone and gum tissues. So that's something that is in my control. If you have good bone and good gum tissues and 4, 5, or 6 relatively good teeth that we can use for 2.5 months, you don't have to wear a temporary denture. And so after 2.5 months, you can see how much pink there is there on the final restoration. It doesn't really negatively impact her smile because the pink matches her pink, and the prosthesis is convex where it touches the tissues. So again, a lot of people get super hung up on having pink. This is the one thing that might be in my control for you, the patient, might not be in my control. So again, just to reiterate, if you've got a few good teeth spread out throughout your arch or your jaw that we can use short term, we can make you a fixed temporary on those teeth and do that staged treatment approach that I've developed. If you don't, then this having some pink on your prosthesis is inevitable. So then there's the patients who have no opportunity for the fixed temporary, and that's kind of what I just said, is that if you come in like this guy, I can't put a temporary on any of those teeth. So all we can hope for is that when I put your implants in, they are stable enough for us to make a fixed temporary on them on the day of surgery. Then we'll be able to maintain most of the architecture that's there, maybe even improve it by 25%. But there are patients who just don't have that opportunity. And in those cases, you'll have some pink. It's not a deal breaker, but it's an emotional deal breaker for some people. That's why I wanted to go through this and talk about it. So he had to wear this temporary denture for 2.5 months because he didn't have enough good teeth and he didn't have enough bone density to give him a fixed temporary. So when we went to convert his denture to his temporary, this is what we ended up with, and this is how it translates into the final restoration. Then the third category is people already missing bone, whether you have teeth or you don't. If you have this gentleman I showed you earlier and said I'd come back to him, so here we are. You can see by how long his teeth are. These are roots. You can see how long by how long the teeth are that he's lost a lot of bone. And you can see he's probably at 60% bone loss the day he comes in for the first appointment. So we did bone grafting back here in his sinuses, and he ended up having to have pink. There's virtually nothing we can do about this. Again, there are some techniques that we can build bone back where it doesn't exist, but you can't have any teeth in your mouth, including a denture, for more than 6 months. So that's a deal breaker for 99.9% of our patients. But again, I want to reiterate, the way this bridge fits with the pink is the exact same way it fits without the pink. It's clean, it's hygienic, and it's convex. So in summary, our goal, well, the pink versus no pink summary is that our goal is no pink on as many patients as we can do it. And as funny as it sounds, you can't argue me into doing no pink when I have to, and you can't demand that you're not going to have pink if you have to have pink. The other alternative is, and I would throw this out there, on this particular patient, we'll go back to this. This young lady right here, if she said absolutely unequivocally no pink, every place you see pink here would be a black triangle. It would be open, there would be no material there, and it would look like you had periodontal disease because your papilla would be missing. We can do it without pink, but nobody would ever accept that. So when I say pink, our goal is 0. This is minimal because all it's doing is replacing her papilla. And then any of the other treatments are a progression of just based on what they were missing when they got here. I don't remove bone in the upper arch. Occasionally in the lower arch we have to, because the lower arch bony anatomy comes to a peak that sometimes is too thin for an implant. So sometimes on the lower we do have to remove a little bit of bone, but it's not going to be alveolectomy, it's going to be alveoplasty. All I'm looking for is to get down to a platform that's 5 millimeters in width so I can put in a 4 millimeter implant in there. It's just math. I mean, again, our goal is no pink. On the upper, I'd say that we're able to do no pink on the upper 80% of the time. On the lower, it's probably only 20 to 30% of the time because of the bone, the natural bony contours, which are very thin. The teeth are really small in the lower. You can look in the mirror and see how small the teeth are. Well, small teeth have small bone, and that's just the way it works. So I hope that addresses the pink versus no pink issue for you. And like I said, we'll have links to many of these other videos that I've mentioned in this video in case you want to dive a little deeper. So as always, thank you so much for putting up with another long presentation, and I hope you found it informative and it will help you make better decisions about your implant treatment. Thank you.